Dear friends and colleagues, welcome to the last webinar on brain, but I want to remind you that all the previous webinars are recorded on the UENPS website. Today we have a very important topic, perinatal arterial ischemic stroke, and our speaker will be an important researcher in this field, Professor Manon Benders, whom I thank for her kind collaboration. Now I will leave the pleasure of introduction of Manon Benders to the chairman, Luca Raminghi. Please, Luca.
Good afternoon. Yes, this is the last module about perinatal neurology. We're very happy with what has been done up to now. We've been very happy with our medicine, in other words. And although we wish to focus on term babies with their problems more important, like HIE or perinatal stroke, because we all feel there is room for improvement. If we compare the many improvements we obtained with the premature babies, we probably haven't not yet reached the same kind of satisfaction in terms of the brain of term babies and these two diseases. For this reason, we asked Professor Manon Benders. She is professor of neonatology in the Utrecht hospital. Utrecht hospital has been for a long while one of the few, is not the most important in Europe, neonatal unit oriented to the brain of babies in terms of research and care. And she's an excellent speaker and researcher. You will hear her speech. She's been in a sense lucky because she's been in such a nice environment with people like Frank Van Belle, Linda De Vries. They guided her at the beginning of her scientific life, but she also spent time outside the unit in many places. I'd like to mention Geneva with Petra Huppi, and also London with David Edwards and many other people that were there to deliver our medicine focused on the brain. So Manon has been an extremely nice producer of scientific papers. A very recent one, I'm sure she will mention, on the perinatal arterial ischemic stroke for the future, potential future treatment. And so we're very happy to introduce such a person, such a scientific person, and this is my pleasure as well to share the friendship with her. Manon. The microphone.
Yes.
Yeah.
Sorry. Thank you very much, Luca, for your nice introduction. And thank you also to your co-chair, Professor Linda De Vries, and also the chair of the UENPS, Professor Moretti, for this very kind invitation. And indeed, I can only give this talk on behalf of my colleagues, else I would not have been able to present the work I will be doing right now. First, I have to make a disclosure. I'm doing consultancy for Chiesi, but nothing has to do with the work I will be presenting today. Today, I will primarily focus on neonatal arterial ischemic stroke. There are more definitions for perinatal stroke, such as cerebral sinovenous thrombosis, hemorrhagic stroke, or even periventricular venous infarction. But for now, I will focus mainly on the PIEs in term infants, and I will say a little bit about preterm infants. So this is a typical presentation of a baby with a perinatal arterial ischemic stroke who had a left side MCA stroke. And this baby girl was 2 days old and showed hemiconvulsions, as you can see on this video. The topics of my talk I would like to point are the following. So I will say something about the presentation of stroke, risk factors, the diagnosis and prognosis, neuroplasticity, and early interventions. So presentation of stroke, the incidence is quite varying in the literature. It's from 1 to 2,300 to 1,500. More boys are affected than girls. Mostly the left side of the brain is affected. And usually the babies present 12 to 36 hours after birth. And the incidence is actually depending on how the diagnosis is made. So if you do an MRI after seizures, the incidence will tremendously increase, also depending on what kind of imaging you will do. And I will point this out later in my talk. And this shows actually the presentation of symptoms described in the International Pediatric Stroke Study, the IPSS, done by Adam Curtin. And most of the babies with a stroke are presenting with seizures. And additionally, you will see signs of a decreased level of conscious, respiratory problems, and feeding problems. The cases shown on the right of the IPSS study is you see an increase in the States, but that's because more clinics are participating in the study. So the risk factors or the pathogenesis. Why does arterial stroke occur? Well, mainly it's a multifactorial combination of maternal and fetal factors. Often there are neonatal difficulties around birth, such as perinatal asphyxia. As you can see here, that there are some maternal, fetal, but also environmental risks. We ourselves also provide a study with an analysis of risk factor analysis in full-term babies with stroke. And we compared 52 babies with a stroke to 3 controls, and this was matched on the same place of delivery. And as you can see here in orange, mainly a lower EPOKRA score and hypoglycemia were risk factors that increased the incidence of stroke. So hypoxic ischemia might play a role in the activation of thrombogenesis in case of these children after a little bit of a difficult start. And we also did the same in preterm infants with stroke. There we had 31 babies matched with 3 controls. And also here you could see that they share a common background in risk factors. There were abnormalities in the CTGs, and also hypoglycemia was imminent. So the presence of thrombophilia as a risk factor is a matter of debate. Several studies have been done who looked at the correlation between thrombophilia and stroke. But all the studies were, of course, done in a retrospective way. And when you evaluate the factors, as you can see here listed in the table, and if you compare the blue bars with the green bars, you see that there's almost no difference. This, of course, does not exclude that there is a possibility of a disordered coagulation. So, and it might be that it's related to hypoxic ischemia. So then I come to the diagnosis and prognosis of arterial ischemic stroke. So this is a baby of 37 weeks old with a normal birth weight. But again, he had a bit of a difficult start, although fast recovery, and the baby was able to join the mother almost immediately after birth. But then he showed seizures on day 2. As you can see here, he is seizing with his right arm and also blinking with his eyes. And if you wait long enough, you also see that the left leg, so it starts to be more a general seizure after it starts on one side. So after he was transported from one to the other hospital, he arrived in our hospital, and in our hospital it's standard clinical care to start immediately with neuromonitoring with the AEG and NERS. And on the first picture, you see here that the EEG signal, and here you can see that the left and the right background pattern is not completely similar. There's a broader pattern on the left side than on the right side. And if you look at the near signal, there was a two-sided NIRS, one on the left side and one on the right side, and it shows that there was an increase in the regional saturation of the affected hemisphere compared to the contralateral hemisphere. And this suggests that the local cerebral perfusion exceeds the metabolic demand, and therefore it might be increased, so abnormal. So one of the first things we do after that is, of course, cranial ultrasound. Cranial ultrasound is useful as a bedside tool, and it also picks up the stroke. However, it takes some days that the echogenicity is developing. So not on the first day you will find often signs of an arterial stroke. So it takes several days to evolve. So additionally, it's also difficult, as you see the window here, to have all the areas of the arterial blood supply in one view. So it could be difficult to pick up several branches of stroke. You can see that the asymmetry takes time to evolve. On day 3, you see barely a difference between the left and the right side. However, if you make an ultrasound at day 5, you see the demarcation line of an MCA stroke, as is confirmed on the MRI, on the diffusion-weighted image, where you see the increased signal of the cytotoxic edema after the MCA stroke with involvement of the posterior limb of the capsula interna. So there are also disadvantages next to timing on cranial ultrasound. And that is that stroke might be missed in many regions, as I said on the former slide. So the posterior and the cortical branches are difficult to catch up, especially in unexperienced hands. Sometimes you can use the posterior fontanelle and might pick it up, but again, it takes time to see the signal after stroke. Although the ultrasound has one advantage, that you can also provide do Doppler, and as you can see here, in the area of stroke, there might be an asymmetry in the Doppler signal, which might be a sign of stroke. So this about the cranial ultrasound. So MRI is actually the gold standard for the diagnosis of stroke. It confirms the diagnosis. You can visualize the location and the size of the infarction better, and it gives you a prognosis. And I will show you that in the coming slides. So here you see a T1 weighted image with a nice myelination of the posterior limb of the internal capsula. And this is a T2 weighted image. And if you look well, you see that the differentiation between the cortex and the white matter has been disappeared. But sometimes the stroke areas are smaller and it's difficult to pick up. And here it's in the acute phase. Its diffusion-weighted imaging is very helpful in showing by the increased signal intensity in the areas where the edema due to stroke appears. So diffusion-weighted image will help you in picking up the stroke. This baby is a baby who also starts seizing 8 hours after birth, and you see already on the cranial ultrasound that there is some echogenicity appearing. Also on the sagittal view, you can see some echogenicity, and here you see the T2 weighted image. Again, there's a loss of signal between the gray matter and the white matter differentiation on several spots. And that is actually far better being picked up by a diffusion-weighted ADC map derived from the ADC sequence. So here a low signal shows the area of stroke. So diffusion-weighted imaging and the derived ADC map is really helping in detecting the stroke areas. What's very important for diffusion-weighted imaging is that the timing of when you perform the diffusion-weighted image is very important. Here you can see, for example, an MR scan of an infant with a vein branch middle cerebral artery stroke, and it was scanned on day 1, as you see in the upper row. And it was repeated after 3 days, you see in the second row. And if you have a closer look at the ADC map, on the first day, you see a little signal change in the, or almost no signal change in the internal capsula and in the cerebral peduncle. However, if we repeat the scan after 3 days, you can eventually see that it's very clearly seen now that there's an increased signal in the peduncle and also in the posterior limb. And this actually corresponds with this MRI scan made at 3 months, as you can see here, where the cavity of the stroke appears, but also you see an asymmetry of both peduncles, which means that this baby probably will develop an hemiplegia. So timing of your diffusion-weighted image is very important. If you do it too early, you might be too early in the full signal of the stroke. And if you do it too late, the signal might pseudo-normalize and you will miss it. So timing is important to perform your diffusion-weighted image after the start of symptoms. So then the consequences of neonatal stroke. This box plots show the different developmental disorders such as cerebral palsy, cognitive deficits, epilepsy, language problems, behavioral problems. And what you see is that about 30% of the babies will develop a cerebral palsy. However, this, of course, is very much depending on the infarct topology. It's depending on the location, on the size, the extent of the infarction, and of course, which specific regions are affected by the stroke. So MRI shows, as I said, with diffusion-weighted image clearly which regions are involved in the stroke, and as you can see here, it's easily to determine the vascular territory that is affected. Here, the main branch of the middle cerebral artery. Here you see the cortical branch, the lenticular striatal branches, the posterior and the anterior cerebral artery. And of course, this is important to know for the additional prognosis. This slide shows the data set of the UMC from 1993 to 2016, and it shows the term and the preterm infants according to the type of strokes that were seen on the several babies we had. And you can see that there's actually a difference between the preterm and the term infants, because in the preterm infants, the perforated MCA was more often affected than in the term babies. And it's also shown in a paper we published a while ago. And here you can see that the differences in the different branches of the several arteries, and you can see that there's a significant difference between the preterm and the term infants according to the lenticulostriatal infarctions. So the stroke type will predict actually what the outcome of the babies are. Here you see a very complicated table, and I will try to help you through because this shows actually all the babies we had described together with the UK, with Francis Cohen and Nienke Wagenaar, the different territories of the stroke and then the different outcomes. And first of all, we see that if the main MCA is involved, you see that 100% of these children will develop cerebral palsy. Although if the other territories are affected, you see that it's only up to 90% of these children will develop CP. So if I show you the former slide where I said that about 30% of these babies develop cerebral palsy, it's good to know which of the territories are affected to give a better prediction to the parents. Next to that is that in babies with an MCA, showed actually 80% of the cases other developmental problems, whereas you can see that this means that is cognitive problems, language problems, but also epilepsy and behavioral problems. And if you then look at those children who will develop normally, that's up to 40 to 50% of the children with the other branches involved in the stroke area. So it's very important if a baby comes in to know which territory is affected to inform the parents in a good way. And we know now that involvement of specific regions are very important for outcome. So the cortical spinal tracts from the motor cortex to the extremities. If this trajectory has been affected, it has consequences for later. And what you see is that what we see on diffusion weighted image, and it's also what the diffusion weighted image shows, is also the network injury. So the axonal injury, so that's injury outside the primary affected vascular territory that shows the prognosis on the long term. So, as I've said before, diffusion weighted helps to predict the outcome, and it shows also the axons that are involved from a distance. So the axons in the cortical spinal tract, when they are affected, and they involve the posterior limb of the capsula interna and the cerebral peduncle, as you can see here. Then this means that this baby will probably develop cerebral palsy later on. And what will happen is that these babies will, because of the affected peduncle, this sign is called pre-Wallerian degeneration. And if you see this, the chance of cerebral palsy is very high. And if you perform a 3-month scan, you can see that there is also an asymmetry in the myelinization of the posterior limb of the capsule interne on this T1 weighted image. So the 3-month scan is very useful for additional prediction. And again, this slide shows the aforementioned Wallerian degeneration. So as you can see here, the peduncle has been affected, seen on the early scan. And if you repeat the scan at 3 months, you see that there does exist an asymmetry between the two peduncles. So there is a degeneration of the descending axons, and that comes from the infarcted areas if the cortical spinal tracts are involved. So the 3-month scan helps in predicting motor outcome at 3 months. And this has also been shown by Adam Curtin. Here you can see several cases where the asymmetry of the peduncles is quite well shown. This has also been described by diffusion tensor imaging, which allows the visualization of the larger cerebral fiber peduncles. So at 3 months of age, it's quite well shown that this baby will develop cerebral palsy. And not only the cortical spinal tracts are very helpful in prediction, but also the DTI can also be used to predict the visual field defects. As we know from the literature, the visual field defects are a well-known complication after stroke. And this actually occurs when the optic radiation is involved. Here you see a stroke with a symmetrical optic radiation on both sides, also shown here on DTI. However, here is a stroke where a part of the optic radiation is involved, and here it's completely gone. And indeed, these children were at risk for peripheral visual field defects. So it helps in also predicting the visual fields. An additional technique to predict outcome, as I said, is AEG and NIRS. They are useful in detecting and diagnosing stroke, but they are also very useful in predicting cognitive outcome. Here you see the EEG signal, where the ipsilateral and the contralateral sides are compared, and there has been looked for the time to recover to a continuous normal voltage, so to a normal background pattern. And you see that there is a difference between the normal and the affected side. And if you look at those children with cognitive deficits, you see that the time to recovery takes longer than those with a normal cognition. So by taking the recovering of the background pattern into account, you can make a prediction of the cognitive outcome. And the same holds true for NIRS. Here you can see the difference between the affected and the non-affected side. And if you look at the asymmetry between the left and the right side, you see that when the bigger the difference, the higher the chance is for cognitive deficits. So it's also useful for predicting outcome according to cognition. And not only the neuromonitoring and the MRI are very helpful in predicting, but also early clinical assessments. And actually the gold standard of CP, I just said, is MRI, but it's often in combination with the early clinical assessments, such as the general movements, the HINE and the HI. And I will say a little bit more about that. Here you see an overview of the general movement and the fidgety movements that are supposed to be seen around the age of below 4 months, around at the age of 3 months. And what you see is that those children who had abnormal fidgety movements also had an abnormal outcome. So it's very predictive when they don't appear at 3 months, that these babies are very high risk for adverse outcome, and it's shown in this slide.
Babies who consistently cramp synchronized, really stiff, really rigid with all their movements.
Where you see very well the difference between a normal baby and baby who has abnormal fidgety movements. I see that the video is sometimes interrupted, so the smooth movements with the large variety of movements is better seen on the left side than on the right side, where you see it's more with a less souplesse than on the left side. And the second early assessment at around 3 to 4 months is the HINE, which is very useful in picking up atypical development, and especially in distinguishing hemiplegia and no cerebral palsy, as you can see in this slide. So those babies, especially for the asymmetry score, it's very sensitive. So for prediction of cerebral palsy. So the HINE will also help as the neurological exam at the age of 3 to 4 months to predict cerebral palsy. And additionally to that, the hand assessment test for infants. Again, this test is also very useful in early picking up the asymmetry, especially of the upper limbs at the age of 3 months. As you can see here, there's a significant difference in the asymmetry index of the high. So it's also, this test is very helpful in predicting outcome. And Nienke Wagenaar, who was a PhD and is now a postdoc in our group, made a combination of the imaging and the clinical function. And with this multivariable prediction model, you see that's extremely well in predicting outcome according to cerebral palsy when you make use of the location of the MRI where the stroke is appearing, and also in combination with the high gestational age and gender. And of course, this needs a well interpretation of the MR, a good interpretation of well-trained doctors for the GMA and HINE. I'm very happy that we announced now a European study where we have a large consortium where we collect babies with perinatal brain injury predicting cerebral palsy. Well, we will try to get a large database with a multidisciplinary team, as you can see here, with also Professor Ramengi is involved, where we try to collect all babies with brain injury from 8 clinical sites with the GMA, so the general movements, the HINE, the MRI, and the EEG. And what we will try to do is with machine learning, do an automatic rating. So also less experienced doctors and less trained doctors can get by automatic rating a prognosis of the children. And what we would like to do as a deliverable at the end of the project is that we have a web-based service where people can upload their scan, their GMA, and their HINE, so that by automatic rating, a prognosis, a more precise prognosis will appear. And these data will, on the long term, be an open access database. So following stroke, we talked about CP and cognitive deficits and also the chance for epilepsy, but there are also behavioral problems. And more studies are appearing now that there is an increased risk of autism after neonatal ischemic stroke. And here it says pediatric stroke, but this study looked at a nation cohort study, and they found a 3-fold increased risk for autism, especially in those infants who had who also developed epilepsy. And also in these children, the risk was even higher. So we have to be aware also of behavioral problems after perinatal stroke. Then I come to the neuroplasticity and the reorganization after stroke. As we know, the neonatal brain can adapt to a situation by its neuroplasticity. This is a very nice recent paper who describes that language and the development of plasticity after stroke is appearing actually after early stroke. And what has been seen is that in stroke babies, and when they are older, they for sure are can be impaired according to their cognitive abilities. But if you look at their accuracy of their vocal or their basic language subsets, you see that there's almost no difference. And that's actually because the tasks have been taken over by the right side of the hemisphere. As you can see on this functional MRIs, this is a normal, these are normal children, and these are children with a stroke. And as you can see here is once the left side has been affected, the right side is taking over according to a language development. So there is neuroplasticity of the brain, and it's actually only in a very early phase. And this has also been seen in the motor tracts after congenital hemiparesis. What this study is a study from a while ago from Martin Stout, and what he has shown is actually that by TMS he could identify patients with a preserved crossed cortical spinal pathways from the affected hemisphere, as well as patients with a reorganized ipsilateral projections from the contralateral side. So here you see that it seems that the function is partly increasing because of the ipsilateral connection. And again, here it's only when the stroke appears in a very early phase, because the networks are developing in this phase, and when stimulation or good use has been stimulated, then it might be that there is some increase in neuroplasticity as well. So it's not only that neuroplasticity and reorganization can save these babies, so it actually needs a help, is what we think. And there are also already described several early interventions, and that's why it's so extremely important to do an early prediction, and several programs has been set up, for example, the early constraint-induced movement therapy. And recently there was also a trial, and I will come up to that in the next slide, by this early stimulation. And I will also go into two more experimental phases for early intervention in the last part of my talk. So this is a very nice study by the group of Adam Curtin, where they did an early intensive lower extremity rehabilitation. What has been shown is that these children, it was possible to do this study in a very early phase, and it also improved the gross motor function on the short term. As you can see here, if they start early, the group that starts immediately with this intervention improves significantly in the gross motor function compared to the other group. Now it has to be seen whether the longer term the improvement also needs additional intervention than this early intervention. But I think it's nice to remind that if we do early diagnosis by early imaging, that we can also start early intervention with an increase of motor function. Next to that, as I said, I will focus on two more experimental therapeutic options from the preclinical work we are doing together with Cora Nijboer. First of all, we know that there are several processes play a role after stroke, such as inflammation and the arrest of pre-oligodendrocyte development. And there are also windows of opportunity that might be important for neuroprotection. But if injury already is there, then we have to think about neuroregenerative strategies, such as the stem cells, and I will say a little bit more about that, but also growth factors might be important after injury. So first, the therapy of mesenchymal stem cells. Mesenchymal stem cells are known to be able to differentiate in different types of cells, but more important, they're also known that they can produce trophic factors, and these trophic factors are immunosuppressive, as we know that after stroke inflammation will appear, and the trophic factors will influence the endogenous neurostem cells in the brain that might help them in differentiating in neurons, astrocytes, and help the oligodendrocytes. So it's not only the stem cells themselves, but also the activation factors. They will be promising for the neuronal stem cells, endogenous neurostem cells. So this therapy actually is brought from bench to bedside nowadays, as Luca already announced. Cora Nijboer, together with Kobe Heijn and Annemieke Kavelaars and Frank van Bel, started this preclinical work where they showed that mesenchymal stem cells reduced the lesion size, improved function, and indeed made a new formation of neurons. And because the intracranial application was too invasive, they thought about an intranasal application, and that actually also showed that it was as effective as the intracranial the intranasal was as effective as the intracranial application. Well, they did a lot of more tests according to timing, dosing, and safety. Well, after that, we decided via the baboon model to go to the human trial. And this is actually the trial we did together with Nienke Wagenaar and Lisanne Baak, where we treated 10 babies with stem cells. As soon as an MCA stroke was confirmed on the MRI, we applied bone marrow-derived allogenic mesenchymal stromal cells intranasally, and we did this by nose drops on both sides of the nose. And for this, this was actually a safety feasibility study, and for this we also looked at outcome, first of all at adverse events, and also at the follow-up MRI at 3 months to see whether there are no signs of infections or tumorigenicity. And we assessed also the motor assessment at the age of 4 months. And what we found actually was that by vision, we thought that there was a less volume loss. As you can see here, this is a non-treated baby with a middle branch of the MCA. And you see the cavity here on 3 months later. This was a baby treated with mesenchymal stem cells, and it looks like in this baby that there is less volume loss. And then at the repeat MRI, we first thought there might be a less volume loss, but of course we cannot compare it with a control group. But at least we saw no signs of infection or tumorigenicity. And what we also saw was the inclusion criteria was that the PLIC should be affected, but only at the age of 3 months, the PLIC was for 40% asymmetrical. And we also performed the motor test at 4 months, such as as I already explained, the GMA, the HIGH, and the HINE. And what we found was based on these tests that only 30% of these children were at risk for developing cerebral palsy. And if you compare that with the general group, then we saw CP in about 44 to 60%, 66%. And as I said, it's very important that part are involved. But since 100% of the PLIC was involved, we only saw 40% asymmetry, and 30% of these children developed a unilateral spastic CP. So seems promising, but of course, compare this with a historical cohort is not enough. So the next step that we will do also volumetric measurements and compare it with the historical group. But in the meantime, we are preparing the RCT trial with long-term follow-up, and we are pending for funding, and we hope, of course, that this will appear soon. And in the meantime, the PREMSTEM study, so it's an EU project, is also busy with the preclinical work to see whether we can also treat babies, preterm babies with brain injury. So that's more the future steps for the stem cells. Additionally, the second experimental trial we are doing is a trial with EPO, or now it's well, this was actually done because EPO was promising in preclinical models, as shown by Sandra Yule. It's neurotrophic, it's anti-inflammatory. That's why we did a safety feasibility study. And based on that, we started an RCT at this very moment. It's called the Dinosaur Study, where we we do this together with 2 clinics in Canada, Alberta Children's Hospital and Sick Kids, with Adam Curtin and Noma Dalimi, where we try to include 80 babies. And so far we are half way the trial, and we will do an interim analysis where we will try to see the effect of the EPO, or in this case, it's a derived product, it's darbepoetin, where we include babies who have a middle cerebral artery stroke, and we randomize them for darbepoetin or placebo, and we will look at the reduction of brain damage by volumetric MRI and DTI. And of course, we don't know results yet, but after the interim analysis, we will see whether there's any chance that we might reach significance at the end of the trial. So that's ongoing work. So to conclude, the pathogenesis of stroke is multifactorial. Often around the birth of the baby, there is, in a sense, something like hypoxic ischemic events that might play a role. The diagnosis, it can be made by ultrasound, but MRI is essential for the prediction of outcome. And for this, timing is very important for the interpretation of diffusion graded imaging. The prognosis, is about 50% will have adverse neurodevelopmental outcome, but of course it's very much depending on stroke. And for this, 3 months MRI gives us additional value. Well, therapeutic options might be available in the near future. And it's, I think, extremely important to remember that EEG neuromonitoring is important immediately after birth. MRI after birth and 3 months is important, together with the early clinical assessments, such as the general movements and the Hein, and the combination might even help us further. And we hope that the development of the early therapeutic intervention will improve outcome also on the short term, and that's where we are busy with the stem cells and the darbepoetin trial. So I would like to thank you for your attention. I would like to thank all our funders to make this work possible, and also especially the people in orange here, Nienke, Lisanne, Niek van der A, Linda de Vries, Marie-Louise, and especially Cora Nijboer, who made it possible to bring this work here. Else I would not have been able to present all the slides I've shown here. And I would like to thank you again for your attention.
Thank you so much, Manon. Really great talk, really comprehensive, giving a lot of insights with great knowledge from the beginning of the story of a perinatal arterial ischemic stroke, how it develops, and also potentials, no, for the interventions, and that you're so, how to say, busy in looking for identifying the best way to repair and to help sort of self-repairment. We have few questions, if you don't mind, to spend some time. You may read on your own, but I can read and summarize as well. There are comments about, because you spoke about, the still debated the role of thrombophilia and blah blah, and so someone is asking if homocysteine may play a role, and it's also something about in utero risk factors for the arterial stroke, and also if you think to same person, Bharat Bakaria, to build up a specific clinic for outpatients for the stroke in order to be more experienced. What's your feeling about those
Well, for the homocysteine, we looked at that, and well, I think also others looked at that, and so far the conclusion is not conclusive, because it seems that the differences between the arterial and the control groups are not that large in infants with stroke and control. So yes, I think it will play a role in the multifactorial etiology, but probably not by itself. Well, can we have a utero stroke, and if so, what are the risk factors? Yes, I mean it's difficult to know when stroke appears. Well, based on the timing, when we do an MRI, we can estimate a bit when stroke did appear, also based on diffusion weighted image, and also the cavity or the cystic lesions that exist afterwards. So in utero stroke can happen, and most of the strokes we saw were around birth. So that's and yeah, also for the risk factors is when there are signs of even mild hypoxic ischemia or then that's one of the risk factors, as I've shown in one of the first slides, where we investigated actually the risk factors between controls and babies with stroke, for as well the term babies as the preterm babies. I don't know if that answers the question.
Well, in the best way, I guess.
And how do we manage babies with a stroke? Well, we are a national neonatal stroke center, where we get a lot of referrals of babies with neonatal stroke. We have a very well-trained and experienced group of doctors in our outpatient clinic, where and Linda can tell far more about it, but we have also physiotherapists and ergotherapists who are helping to evaluate the babies and also give early advices to the parents how to approach their children, and if necessary we also start the early sim therapy. So yeah, and I think it's good, as I said, to do the clinical, to be trained in the early clinical assessments, such as general movements and the Hein, because that is really of additional value for the prediction of your children. And yes, you can follow specific courses to be a certified user of the GMA. So that's a well-known course.
There are so many questions. I'm not sure we can answer to all of them. I mean, Linda, would you make a comment or to say something about that? Because there are a lot of things emerging from the question. I'm trying to pick up, I don't know, something like mentioning aspirin. What's your feeling about mesenchymal cell therapy? As I suppose was giving a lot of enthusiasm. When they will be available, in your gut feeling? You're optimistic, so you may say something shortly. And also hypothermia in the way of treating. In the meanwhile, if Linda is happy to make a comment or things like that. Hypothermia and stroke, because I think this was a good question too.
So hypothermia, it has been investigated, and hypothermia is of course useful when you start within 6 hours after the hypoxic ischemic event. And that's, I think, also referring to the former question, sometimes difficult to estimate when the stroke is appearing or when it's existing. So I think therefore also the hypothermia was not that useful. And of course, hypothermia is affecting the whole body, where you have a very local problem in the brain. So, well, the trials did not show any significant effect on these children, but it could also be according to timing.
Yeah, I think one of the questions, Manon, is also, again, what is the best timing for using diffusion-weighted imaging? I think that's an important one to address.
Yeah, very important. So that would be, well, before, well, after symptoms, it will be as I've shown, the timing matters. I mean, you see that don't do it too early because you also miss some injury. So do it after 2 to 3 days, and also do it before 7 days after the stroke. Before, also because I've shown that the diffusion weighted the restrictions will disappear, so you get a kind of pseudo normalization in your diffusion weighted image. So yeah, to be more concrete, somewhere between day 3 and 7 would be most ideal after starting.
Linda, this could be how to say, a crucial point for the meeting with the mentioning before about MRIing babies, because we were thinking, I don't know if you heard it before, that we may produce a sort of roundtable about this issue, because maybe not all of us may fit totally with your idea of waiting 2 days when you have a fitting baby. So
I know, that's a problem in our consortium as well.
Yeah. So really, thanks for that. So we get other few minutes to pick up something from the questions. Yeah, Linda.
Look, there's also a question about how you treated neonatal seizures.
Yeah, seizures.
Oh yeah.
And maybe also, Manon, say a little bit about the post-neonatal epilepsy, because if the children develop hypsarrhythmia afterwards, of course, that will have an impact on their cognition.
Yeah, so well, we have a standard national protocol where we start with phenobarbital and then midazolam, and then there's some debate about lidocaine, midazolam, what to start first, and additionally Keppra. So that's our protocol. Well, what we now are actually doing is an EEG at the age of 3 months to pick up postnatal epilepsy, but also we're of course very aware and very we should be aware whether epilepsy starts after stroke. The age is kind of difficult. The larger the stroke, of course, the earlier symptom starts. But that's Linda. You can probably say more about it when to be expected and when EEGs should be made if there are any suspected absences or deviations of development or other things. I mean, I don't know whether you want to say a little bit more about it.
No, I just always find it very difficult because you know that if the child does develop hypsarrhythmia, the outcome is going to be so much worse. So I'm always relieved if they do not develop it and the first 6 months have kind of passed and it's less likely that it will still happen. But of course, these children can get epilepsy up till 8 years or so, still after the stroke event. So I don't know. I think we need a good prediction of who is going to get epilepsy later on and who isn't.
Yeah, we're trying to do that now, to differentiate that now on the larger cohort we have together with the sick kids. But it's extremely difficult to do it based on the location. Maybe if we look, makes one step further, if we do it based on the network that's affected, as I've shown that there's always axonal injury on the distance. So maybe if we make use of the network where the injury is connected to, then we might be better in predicting, but that's still future work. I mean,
So I think we probably addressed the majority of the questions. I mean, I forgot to mention all the congratulations, Manon. So plenty of congratulations. Also from quite few people, very happy. And so I think this has been a very important day. So if you're happy about the message that is really updated in terms of the current efforts we're doing to improve the outcome of these babies. There are still some worries. I don't know if you want to make a comment about autistic spectrum is a bit everywhere, to be honest, no?